Hi everyone, welcome. We're just giving people a couple of minutes to get here so we start on time, but please feel free to use the chat to say hello. And many of us will be used to using Zoom, but you'll see the options at the bottom of your screen, so please do feel that you can use the chat if you've got any questions you'd like to ask as we go through the session. And thanks to colleagues who are keeping all the technology going, but let's just make sure we might not all be used to using it, so be patient with each other as we do use it. And everyone is very welcome. We're delighted to be having our World Reimagined series, our social care conversations, and delighted to be doing this in collaboration with Strathclyde University. And really important, we're having these conversations relating to the independent review of adult social care. And we've already had some really amazing conversations. So thank you all for coming here again. And today is going to be led by Dr. Elka Luthler from Strathclyde University, senior lecturer, there with a lovely background, looking like she's in nature. Yeah, delighted to have Elka here leading a session with a range of people who are really going to have great contributions to make about co-production in social care in Scotland and internationally, and a really important aspect of the review, but also in terms of how we build services that are really the right thing for everyone and for the people who use them in particular. So I'm not going to delay any further. We are recording the session, and that's so that we can share the presentations. So if you'd rather not be, we'll not be sharing the breakout sessions and that bit, but we will be sharing the presentation. So if you're more comfortable with your camera off, please do that. And as I say, we'll keep an eye on the chat for questions, and we'll be flexible with our agenda in response to that. So over to Elka. Thank you for being here.
Okay, many thanks for the kind introduction, Sheena, and a warm welcome to everybody. I'm absolutely delighted about this webinar and would like to thank the GCVS for taking this initiative. My thanks also goes to Lynn Williams, who's been very active behind the scenes in preparing this webinar. I guess that for most of you, co-production is actually not a new topic. And looking back, it's already been highlighted by the Christie Commission almost already 10 years ago. And of course, more recently, as Sheena said, it was also highlighted in the Feeley report. So my presentation will provide you with a systematic framework of co-production based on my research, as well as a number of UK and international case studies. And this also includes a case study from Riley Livingstone, who is with us joining us from Canada today, who will provide a case study from Quebec. And of course, we are looking forward on what you're doing in terms of co-production, to hear about your experience, but also the challenges you experience. So as you saw from the program, we've provided for lots of space for discussion. And we want to keep this whole webinar as interactive as possible in the spirit of co-production. So I'm now bring up some slides. I won't show a lot of slides, but just a few to give us all a framework. And first of all, I would like to discuss with you what is user and community co-production. And of course, there are lots of definitions which are around. But before we are looking into definitions, I got an icebreaker for you with, I think, actually quite straightforward question. And this question is, what do you think people with visual impairments need most? And I would like to invite you to discuss this question in 3 minutes with 3 other people. So Tracy, if you could please set up some breakout rooms and invite everybody to join the breakout rooms. The breakout rooms will be random, so you won't necessarily meet your friend, but this is a chance, I think, to make some new contacts. So please join the breakout rooms and feed in the results, the ideas you have in the chat line once you return back to the main room, okay? So looking forward to your inputs. Okay, this seems to be working well. Okay, I'm going to close the meeting rooms. Okay, people are coming back, that's good. So for all of you who have already come back to the main room, you can start typing in your feedback into the chat line. It doesn't matter if you had several ideas, you don't need to agree on one idea, you didn't have enough time. Okay, so everybody should be back. So please feed in your answers, the ideas you had in the chat line. A number of you have already used it to introduce themselves. And for all those of you who are joining now, simply have a think, what do people with visual impairments need most? And I've got here, I'll hold it in the camera, a very nice chocolate box for the best answer, just to incentivize you. So I'm really looking forward to your ideas. Okay, we already got a first input. To be treated the same as everyone else, that's great. To be asked what they need, that's already a very good answer. Make no assumptions. For people with visual impairments, remain mindful that their experience is not the only one. Absolutely, there are other ones. Riley said our room has said a lot about friends because they become so isolated, their friends leave them. I wonder, Riley, if you have shared my slides with the participants in your breakout room, because I'll get back to that. That's a very interesting answer.
I have not.
And we've got information in accessible formats. An environment that is accessible, so that's a similar proposal. Information in an accessible form, so accessibility is an issue. And what do other people, non-visual impaired people, to presume to know what visually impaired people might need most? No assumptions. Okay, I think that's all great. I think one key input I've taken away from you is that you're saying we don't know, we have to ask. And that's exactly now my slides got stuck. Sorry, I got to go off that. I'll go back just a moment because I was in full screen mode. Wait, let me exit. I'll be back. Let me just get this back up again. That's always a little technical hitch. Okay, so that's exactly what the University of Birmingham undertook a study where, first of all, they asked public managers and staff working with people with visual impairments exactly the same question, which we just discussed. And here you can see the answer. 64% said more information about public services. 54% said more information about specific support. That's what a number of you have suggested, such as accessibility. And in a second step, the research team also asked people with visual impairments, what do you want? and have a look at the answers. Interestingly, 91% said get to know people and make friends. 62% said to talk with someone about personal issues. And Riley, I don't know, you'll be able to identify the participants in your group. I think they all deserve the chocolate box. I'm going to send that by post if you send me your postal address in the chat line. But I think the answer, if you compare the answers, there are two important lessons. First of all, we should make no assumptions, and that's what a majority of you have suggested. And secondly, if you look at the answers, what people with visual impairments really want, public services are of course still important, but more important are public outcomes. And these outcomes are co-produced friendship. That's something mutual and something where two sides need to make a contribution. In other words, this is not a typical public service. This requires co-production with people accessing services, with their families, with their friends, with their carers. And this brings us to co-production. Now, if you have a look on the web, you will find lots of definitions of co-production. The definition I've been using in my research says co-production of public services means public service organizations and citizens making better use of each other's assets, resources, and contributions to achieve better outcomes or improved efficiency. In other words, it takes two. I use here the fish and chips icon. I think that's still quite popular in Scotland. For Germany, I always use a bread roll and a sausage, of course. And most important is the mustard. You know, co-production is not a purpose in itself. It's about synergy. Hence, you know, fish and chips looks a bit different than a raw fish and raw potato. So what does why is co-production, or in which respect is co-production different from other forms of citizen engagement? Well, I think first of all, it sees service users and local communities as active contributors and asset holders. And that means that in social care, we have to ask a new question. Not only what do you need, which is still a very important question to ask, but also a new question. And I wonder if you can guess what this question is. We have to ask, what can you do? What are you doing already? And in my experience, this question is still not commonly asked. These kind of asset-based assessments could be done more systematically, something to be discussed later. Secondly, co-production promotes collaboration rather than paternalistic relationships, puts the focus more on outcomes rather than on services, as we just learned from this exercise. And it enhances the role of local councillors as community enablers and guardians of good governance. Would be interesting to know how many participants here are also local councillors. So how can we put co-production into practice? In my practical work and research, I have developed the so-called 4CO model, which includes 4 key co-production approaches, including co-commissioning. This is about deciding together what matters most, about prioritizing together. You could also use the term co-planning if you like. Co-design, this is about innovating together. Co-delivery, this is about putting innovations into practice, about implementing together, and co-assessment is about undertaking joint evaluation on what works. So let's have a look at some case studies, how these 4 Co's can be put into practice. The first case study is about co-commissioning young people services in Surrey County Council. And as you will guess, this is quite a rich council, but nevertheless, it experienced a relatively high number of young people categorized as NEET over 10 years. NEET stands for not in education, employment, or training. So eventually, a team got together and decided to undertake a comprehensive transformation process, which also included interesting co-commissioning approaches. And this included, first of all, designing an outcome-based framework together with young people. And they said, what matters most to us is getting a job. So improving employability was the top outcome in this framework. Young people were also involved in commissioning processes, in particular in prevention services. And people told me in interviews that the young people made a real difference because they focus much more on outcomes than on services. And the commissioning approach also put a very strong focus on prevention and effective support for very disadvantaged young people. And of course, that was also very courageous. The council took 3 years to plan the strategy because it was so comprehensive, but then implemented it within 2 years. And you can see that the results were quite dramatic, a 60% reduction in the number of young people who were in need within 2 years. This case study is now almost 10 years old, and I'm waiting for a new case study from Scotland. So if any one of you has equally dramatic results from a co-commissioning initiative, I would be very interested to hear from you. So this now leads us to a case study on co-design. And here I would like to invite my co-speaker, Jenny Miller from PAMIS, to provide us with a really intriguing example. Jenny, you got the floor.
Okay, thank you very much. Yeah, this is a piece of work that PAMIS, well, it was led by a family carer who's with us today, Jenny Wynette, and she will tell you more about it as part of our example. But one of the biggest causes of death in children and young people and adults is due to body shape distortion, and that it was an area that really wasn't getting the limelight and wasn't really being understood. Family carers weren't being given messages early enough, and practitioners seemed to have a mixed model of how they informed families and how they trained. So Jenny actually brought the training up to Scotland, and for the last 10 years has been really pushing this model. But more recently, NHS Education for Scotland and the Scottish Government became involved, recognised that the family carer message about needing to make sure that people understood about postural care, and at a very early stage needed to be moved forward. And they commissioned families and PAMIS to work together with allied health professions to co-design a postural care strategy for Scotland, which again, a bit like the previous slide, has taken a number of years. It has escalated actually because of COVID, because suddenly everybody wants to know about postural care. And one of the key areas that we were really promoting was that family carer story, but also the co-training, that family carers actually co-trained alongside practitioners. So what has happened is the postural care strategy was launched just earlier. It was co-written and co-authored by a group of family carers who actually gave up their time with intense caring roles, but throughout COVID and met together and worked together. First month of it, there's been 3,000 visitors. We had over 600 people at 2 webinars about this whole approach. And in 2020, there were 33 people that were co-trained, and 78% reported that their skills and knowledge had improved. And from the allied health professions, they actually said the biggest impact had been hearing those stories from family carers. So now family carers are being invited by allied health professions to be co-trainers, and we've also just been commissioned with the Scottish Learning Disability Observatory to take part in a postural care video with the hope to reduce the mortality rates of people with a learning disability. So started by a family and then joined together and then co-hosted, and we will be co-evaluating what the impact is as we move forward.
Well, that's great. Many thanks, Jenny. And you also showed one co can lead to another co. So that was a great case study. I'm going to skip the next case study. Obviously, co-delivery also plays a big role in behavior change. And this is a case study about falls prevention. You can look it up on the Governance International website. And I'm now going to Canada, and I would like to invite Riley Livingstone, who is a PhD student at Strathclyde University, to talk us through this really interesting co-delivery initiative for older people in Quebec. So Riley, you've got the floor.
Great. Thank you, Elke, for that introduction. So another example of co-delivery of public services can be seen in this approach to caring for older people in Quebec. So as of 1996, the provincial government has provided partial funding to what's known as SEEs, or social economic enterprises, that deliver domestic help services. And so the objectives of this initiative were to address the major unmet social need of quality domestic help services, and also to create quality jobs, particularly for women who tend to dominate the domestic help occupations. So because SEEs are partially funded by the government, and because the service they deliver complements the available suite of publicly offered services, we can consider this an example of co-delivery. So most of their income, the SEEs, come from charges to service users, but this is backed by a provincial government grant that represents 15 to 20% of total revenue. As well, service users who choose to use SEE services over the other services out there are qualified for special financial assistance against the hourly rate. All SEEs are either community cooperatives or nonprofit organizations. And part of this is because in order to receive this grant, they have to qualify as a domestic help social enterprise, social economic enterprise. And some of the criteria to do that will naturally lend itself away from for-profit. So they must include the democratic and systematic involvement of all the service users and workers in operations, and all the financial surplus has to go back into the promotion of people in work. In terms of their results, by 2007, 101 domestic help social economic enterprises had been established, employing 6,000 staff, 90% of whom are women, so helping towards creating quality jobs, and 5.1 million hours of service had been provided to 76,000 service users, with sales close to 106 million Canadian dollars going back into the Quebec economy. So quite a large scale and effective implementation of co-delivery of a service. But again, quite an old case study, because 2007 is those results. But yes, anyway, thank you. That is.
Okay, well, thanks a lot, Riley. And I think that's an interesting model for Scotland, given the strong focus on social enterprises. And again, it shows co-production takes time. But again, that's another case study which has been active for quite a while. Finally, an example on co-assessment. Obviously, there are lots of forms of co-assessment. West Lothian Council has been inviting citizens to undertake a training as citizen inspectors, in quotation marks, and to take part in inspections of all kinds of services, including winter maintenance, pupil placement. They provide a feedback report, which is published on the website. So this is very transparent. And as you can see from the quotation here, the involved citizens feel very valued. They actually enjoy being part of inspection teams. And this has brought about a lot of improvements, which you can also read up on the website. So this raises the question, there are lots of inspiring case studies, but what are actually the benefits and limitations of youth and community co-production? Well, if we look at the research, there are lots of potential benefits of co-production for key stakeholder groups. And in my experience, it's important to evidence these benefits and also to communicate them well to different groups. But of course, co-production is not a panacea. There are various limitations. Not everybody wants to co-produce. Not everybody can co-produce. So we need a variety of service models. I often hear that co-production may bring some risk, but my research also shows that it might also help to decrease some risks. And most importantly, co-production is not free. It requires resources and investment for its potential to be realized, both from the public sector, but also from local communities. So this brings us to a question raised in the Feeley report. What are the barriers to scaling youth and community co-production? And if you look at the literature, A couple of barriers are suggested, such as funding and commissioning practices, which don't promote co-production, difficulties in generating evidence, of course, very important issue for researchers like Riley and myself, lack of staff skills for co-production, so there seems to be a lack of training, a lack of hands-on experience. I have also undertaken some research on this issue and added as another barrier risk aversion in the public sector, which often puts more emphasis on risk to organizations rather than on risk to involved citizen co-producers, and also political and professional reluctance to lose status and control. So the Feeley report comes to the conclusion that the problem is not that we do not have good ideas, it is that we have not acted on them at scale and with genuine commitment. And indeed, like the Feeley report, I have come across lots of inspiring practices, but the question is, how can we scale these co-production initiatives? So the report recommends a national approach to improvement and innovation in social care, to create a culture of experimentation to improve outcomes, and a focus on involving people who use services, their families and carers in developing new approaches. We'd be interested to hear from you what you think of these ideas. What are your ideas? That's something we'll discuss in the breakout rooms. Finally, some critical perspectives on co-production. First of all, you need to be aware that obviously not all forms of co-production are effective. Hence, it's important to evaluate co-production like any other form of service delivery. In particular, co-production can sometimes have unfavorable or negative cost-benefit ratios. It may also shift costs to citizens. Obviously, this was a big issue under recent austerity regimes. I've often heard, the criticism that it may exploit service users, communities contributing to co-production initiatives. And finally, there's evidence that co-production may also entail governance pitfalls, such as a lack of accountability, transparency, diversity, and compliance with rule of law. So we need to be alert, critical, but I think there's also appetite and need to experiment a lot more with co-production. So if this has given you appetite to explore more what co-production is about, what the research findings are, I warmly recommend you to order already now for Christmas, given delivery issues, the Palgrave Handbook of Co-production of Public Services and Outcomes. I think it's about 400 to 500 pages, and it's a handbook which I co-edited with Tony Beauvert. So something you may want to have a look at. For now, we would like to thank you for your attention. And I'm here doing stop share screen. And I suggest if you have any comments, questions, make a note, because I would like to move us to the next presentation, which is from PAMIS, from Jenny Miller and her team. And I think that PAMIS will provide us with a real intriguing insights, what it is, how it feels like putting co-production into practice, in particular in dealing, in helping and supporting people facing lots of complex issues. So I would like to invite Jenny and Pat to take the floor. And we got Jenny Winnett as well, sorry.
It's okay.
I didn't have you all on screen,
I need to share my screen now.
That's fine. Should be working. So far, we coped well with technology, so fingers crossed. Good.
Okay.
Yep, that's fine. Thanks, Pat.
Okay, Jenny, over to you.
That's great. I have very unlike me, have decided that I would write down what I was going to say, and partly because I knew I would be so excited about all the things that Efke's just told us, and that sets my mind racing. So I am absolutely delighted and actually feel very honoured to be asked today as part of today's session. And Co-production has been at the heart of PAMIS from the onset, and I guess I can say that quite confidently because it wasn't me that set it up. And the reason that we have Loretta, I will explain in a minute, who was the founder of PAMIS. So PAMIS are an organisation that stands for Promoting a More Inclusive Society, and actually we're the only third sector organisation that solely supports children, young people and adults who have a profound learning and multiple disabilities and their families, and we're there to promote them to lead healthy, valued and inclusive lives. We've played with that word profound and passionately believe it means deep, and it means wise, and it means expert. And actually for 29 years, we have learned from these experts, people who have a profound learning disability and their family carers. And what they teach us is they teach us how to care. They teach us how to act with compassion. They teach us how to really listen. And they teach us how to be creative and innovative. And above all, I think they teach us how to work as a team and how to collaborate. So my reason for having Loretta on the first slide, who sits on my shoulder throughout my life, is that she was the founder of PAMIS and in my opinion was a real expert in looking at how to put co-production into action. She heard from a group of families over 30 years ago when she worked from ManCat that they were feeling that they were invisible, even within the community of people with a learning disability, and that the advice and support never quite seemed to fit their needs. And although they were trying to advocate for their child or relative with a profound disability, they didn't feel they were being acknowledged or heard. Well, Loretta heard that, and in 1992, PAMIS was born. And immediately she set to meet with families to find out what their key issues and their key asks and their key needs were. And actually, as I reflected back, I realized that as a very young occupational therapist, I, in those very early days, was part of one of the first groups that was identified. And it was a need that families felt that moving and transferring their relative, moving and handling, as we called it, was a real issue for them. And actually, I can still remember feeling incredibly anxious about whether my information and advice would support this group. And it's maybe a little bit like I'm feeling today. Who am I to tell such experts about what I think? And on reflection, I probably hadn't co-communicated and worked with the families to find out exactly what they expected from me. I think I was too busy panicking. But anyway, I arrived and was absolutely welcomed in. And immediately, because of the way Loretta set up the workshops, the families engaged, and together we looked at issues and worked out solutions. And I have to say, I think that first workshop transformed my career and my working practice. And looking back, I think it was because Loretta was such a stickler for the detail and for involvement of these real experts in the care, the families, in experts in care, which are the families themselves. From this early start, I, as a practitioner, joined a practitioner para-consultative group, and it's quite interesting, really, looking at that question about what is it that's most important for families. And one of the key areas that came out by the families was not something I would have ever expected. But the biggest perspective of them and the biggest issue was that they couldn't go shopping because the shopping trolleys in supermarkets weren't appropriate when you had a very unusually large or unusual wheelchair. And how on earth do you attach a shopping trolley to that wheelchair? So that was quite an eye-opener and an area I foolishly had never thought about. But it developed into a partnership with one of the supermarkets, and we all innovated together. We worked together with various designs and prototypes, and we evaluated together. And this was also really early days of looking at the role of families and their relatives with profound learning disabilities in messaging together, and their involvement in conferences and education of others, in cross-party groups and campaigning. And the Changing Places toilets, which I couldn't ever do a presentation without mention, came out of this. So that is a whole other story. And please look on our social media pages to see what the other part of P, perseverance, stands for. So throughout my career, I've taken this model that Loretta embedded in PAMIS with me. Ensure families and those with lived experience who are the experts in care and understanding of their relative are at the centre of any decisions and plans. Enable them to take their role through very careful planning. And by this, Loretta insisted that times were suitable for families to meet, never meet before 10:30, always finish by 2, that their relative had their needs met so that the family member were able to contribute without the worrying of their caring role, that their basic needs of getting to the venue, having an accessible venue with a changing place toilet, and were incorporated, and that the refreshments were appropriate. Loretta always made sure that these were a real treat. As she said, families rarely got the time for lunch themselves, and she wanted this to be a special part of the session. And it also promoted discussion and connections. And I use that approach actually in consultations. I remember doing one in a health board, and I was very proud that my cheese and wine and evening session hit an all-time record for involvement, rather than a 3 o'clock afternoon cup of tea in a boardroom where nobody was able to come. So I think, you know, the research, Aki, that you described so well, co-communicate, co-design, innovate together, work together, and evaluate together, makes such a difference. And actually, it still excites me, because who knows what we will come up with when we all work together. There is usually a profound impact, and hopefully the basis for a new world of social care. But this wouldn't be a proper co-produced presentation if I didn't pass you on immediately to Pat and Jenny, who are both lifelong members of PAMIS community and also part of our PAMIS Board of Governors. That ensures that we as an organisation are always directed by the wisdom of those that are real experts in the group. And they're going to further explore the PAMIS model with their personal examples. So I will be quiet and hand over to you two.
I'm not sure why I can't move on to the next slide. Oh, there we are. Sorry, everyone. So I'm going to tell you about my family's experience over the last 3 years of a situation that's been an example of co-production with PAMIS, but the outcome of which would have been so much more positive and productive if our efforts at co-production with the HSCP, the NHS and the Ombudsman had been more successful. So although I work closely with PAMIS and I'm in fact the chair of the PAMIS board, the comments and views expressed, some of which may be perceived as controversial, are very much my own and reflect our family's personal experiences. So my daughter Lauren is 32 and has a profound learning disability and complex epilepsy. She's non-verbal, doubly incontinent and has little awareness of danger. She's on the autistic spectrum because of her communication difficulties. She is, however, very active and needs one-to-one supervision and company at all times. Lauren lives in a housing support service with 3 others and is happy there and visits the family home 3 times a week. She's currently being treated by both a physiotherapist and an osteopath because of physical problems directly attributable to the reduction in her activity as a result of the pandemic. I'm very actively involved in supporting both Lauren and our care providers to ensure that she has the best possible quality of life. I'm Lauren's welfare guardian, so I not only have a parental and moral obligation to safeguard Lauren's well-being and promote her interests, but also a legal obligation to do so. So everything I've said so far relates to Lauren's circumstances and not to who she is. She's a person who loves to smile, to laugh and have fun. She always wants to give kisses and cuddles. She enjoys lots of activities, including her swimming, going for a drive, being read picture books, being out and about, and most importantly, listening to and watching the music that she likes, and especially being sung to. We found out in October 2018 from Lauren's staff that should she have to be admitted to hospital, it was social work's policy that paid carers for people with special needs would not be funded when they were in hospital. The onus would fall to me as her mother, regardless of my circumstances, to provide any non-medical care that she would require. Furthermore, during the night, there was a very real possibility that she'd have to be put in an ambulance and be left in A&E unaccompanied and supported only by a paper hospital passport. If she isn't supported in a hospital setting by people who know, understand and can communicate on her behalf, she's an extremely high risk both to herself and to others. However, in the event of her being admitted to hospital, social work guidelines ensured that she wouldn't have any support from her paid carers, despite their having assessed her as needing one-to-one support at all times. There have been 2 occasions where the clinical decision by consultants was that Lauren should be admitted to hospital because of issues relating to her epilepsy, but both times she's had to be sent home because social work would not fund her care staff in hospital, and hospital staff considered that they wouldn't be able to provide the care and supervision that Lauren would need. Here's a photo of Lauren in hospital when she had to be sent home but should have been admitted for a week's observation. The black eye resulted from a seizure that threw her across the bathroom and smashed her against a tiled wall. For almost 3 years now, we've been trying to persuade the HSCP, the NHS and the Ombudsman of the need for Lauren to be appropriately supported in a hospital setting. The Ombudsman's decision was that the HSCP and the NHS should consider Lauren's profound learning disability and complex needs as being unmet, and stipulated that a joint emergency contingency plan be drawn up in consultation with ourselves to ensure that her needs are met. The HSCP was tasked with arranging that joint meeting within 4 weeks, but 10 months later, we're still waiting. My partner and I have spent so much time and effort trying to resolve this for Lauren and others in her situation, but we've been supported throughout by many organisations and individuals we've contacted, all of whom were sympathetic and many of whom were appalled. There are too many to mention, but PAMIS has stood by us throughout. Our perseverance and PAMIS's efforts on our behalf were rewarded by the Scottish Government's civil servants and Jean Freeman's letter in November 2020, which applies across Scotland and endorsed all the points that we'd been arguing for. She made it clear that it's a legal requirement to make reasonable adjustments for people with disabilities. By implication, therefore, some HSCPs and NHS boards had not been fulfilling that legal obligation. This was a major success and demonstrated the value of a co-production between family carers, the third sector, and the Scottish Government. This begs the question, though, how successful would our efforts have been if the HSCP and the NHS had been parties to that co-production? Despite this enormous step forward, we've still struggled to persuade those in a position to make the necessary changes to speak to us about how best to resolve matters. However, there's still some way to go. Although we've made some very recent progress because of a contact of Jenny's. The current interim arrangements are that Lauren may be supported by her care staff in hospital during the day, but for emotional support and comfort only, which would be wholly inadequate for her needs. Furthermore, the position around her being supported overnight in an ambulance and in A&E remain unresolved. The outcomes for Lauren and others with learning disabilities could have been so much enhanced had there been an effective co-production between ourselves, other interested parties, the HSCP and the NHS. However, our interactions were typified by delays in replying and sharing information, obfuscation, failure to consider the legal position, reluctance to answer reasonable questions, and unwillingness to meet with us. Much of the delay was put down to the pandemic, despite our argument that the pandemic made it even more urgent for this situation to be resolved rather than less. If more effort had been put into making the reasonable adjustments required by the legislation, as opposed to defending the indefensible, then it should have been possible to arrive at a mutually beneficial solution. So what have I learned so far from 3 years of researching, complaining, writing, discussing, meeting, networking, cajoling, and throughout all of this time, a deep-seated concern for my child's well-being and safety? We need clear hospital pathways for people with PMLD, a PMLD index so that they can be recognised and traced, a PMLD hub in each acute hospital, leading to greater expertise, understanding and cooperation, HSCPs and NHS boards who talk to each other about how best to meet our needs, a robust, equitable, consultative planning process, greater accountability on the part of the NHS and the HSCPs, particularly where they publish mission statements with values and visions that bear little resemblance to the service that we actually receive, a clear understanding of when equality impact assessments are required, and crucially, we need them to talk to us, the families, the experts, to give us our place and to treat us with respect so that we no longer have to go cap in hand to ask for what others take for granted. The most fundamental lesson that COVID has taught me is that there is no magic bullet, that we're not all in this together, and that no, the cavalry isn't coming. For our PMLD guys, Where was the PPE, the testing, the vaccines, the services, the allied health professionals, the care home visits, the support for abandoned carers, the social workers, the outraged newspaper headlines? PAMIS is a very small charity that very much punches above its weight, but we were so grateful that they, at least, were there for us. We have to shout loud for ourselves and our children in the hope that someone, somewhere, is listening. That's why I'm here today talking to you, because our best hope for the future is that people like yourselves will listen and hear us and become our cavalry. Mahatma Gandhi famously said, the true measure of any society can be found in how it treats its most vulnerable members. What we need in our decision makers is a greater degree of empathy. My mum used to say when people stared at Lauren, walk a mile in my moccasins. That's the kind of culture we need. What if it was your child with a disability? What if it was your sister, your friend, someone you love or you care for? What if it was you? Wouldn't you like to think that the starting point in any decision-making process was the person with the disability? And how do we achieve all of this? It's clear that we have to work together to co-produce with all of the interested parties. Then maybe, just maybe, we can make those changes happen. Thank you. I'm going to hand over to Jenny Winnett now, who has a rather more positive outcome of co-production.
Thank you. Right. Thanks very much. Oh, right. PAMIS has worked consistently for over 15 years to have a postural care training available in Scotland for family carers, people with postural care needs, and professionals. The training has been led by PAMIS Director Michelle Morrison with a senior...
Excuse me, Jenny, are you needing to share your screen?
Yes. Oh, I thought it was.
I'm not seeing it.
Oh, hold on a minute. It's everything's... Oh, I've come off. Hold on. Where am I?
We can share it, Jenny. Hold on a wee second, I'll do it for you.
Okay, I'm going back. Can you see it?
Not yet, Jenny, no.
Oh, I had it all up.
Go,
Yeah.
Is that
It's
Jenny?
coming on now.
Yeah, there we go, Jane. I put it up for you. Do you want to just let me know when you want to share the slides?
It's okay. I'm sorry about that. I don't know what happened there because it was on. Okay.
There you go. Okay,
Yep.
thank you.
Right. Thank you very much. Okay, I'll start again. Sorry. Right. PAMIS has worked consistently for over 15 years to have postural care training available in Scotland for family carers, people with postural care needs, and professionals. The training has been led by PAMIS Director Michelle Morrison with a senior physiotherapist, Elizabeth Duff, and family carers Jenny Winnett, Mary McCardle, Emma Parley, and Caroline Hunter. The start of PAMIS involvement was due to my family experiences with my son Craig, who experienced severe body distortion, resulting in medical issues, pain, and a shortened life, because I didn't have information on 24-hour postural care throughout most of my son's life. I gained training in 24-hour postural care shortly before my son Craig died through Postural Care Skills, the lead organisation in the UK promoting postural care at that time. And it was a light bulb moment for me. I realised that all family carers supporting people with body shape issues needed the information and training I had been given on how to protect body shape and to be empowered to work co-productively with their adult allied professionals. I also believe the success of the training was professionals and family carers to be trained together as I had experienced. PAMIS, led by Michelle Morrison, worked to promote this training to family carers, professionals, and empowered family carers as postural care champions. Following the accredited training on postural care, senior physiotherapist Elizabeth Duff and I completed the training to be a trainer. And through PAMIS, we held accredited training workshops for family carers and professionals. Please change. PAMIS was granted self-management funding from Health and Social Care Alliance because the importance of 24-hour postural care was recognised for everyone with body shape issues, and professionals, family carers, and people who need postural care saw the need for a postural care strategy for Scotland. However, family carers wanted to have a real role in creating the strategy, but recognised they needed support to do that. They also wished to continue to build their skills and knowledge in postural care and in delivering training to family carers and professionals using a buddying system, and begin delivering postural care education courses in 3 areas. Change slide, please. You change slide, please.
I am, Jenny. It's taking its time. So enjoy your technology. Just keep talking. It should change.
All right. This slide, the next slide, will identify all the outcomes from the funding, but the important ones I wish to highlight is that family carers were to gain the confidence, skills, and knowledge to deliver training in postural care and moving and handling. They were to show that they can be seen as equal partners in gaining and sharing knowledge and share experiences. They were to be supported to be involved in the design and delivery of the postural care strategy and training framework, and to contribute to raising awareness of postural care across Scotland. They were to represent people with PMLD within the strategy and contribute to best practice. They were also to contribute to the PAMIS moving and handling training and to be supported to move and assist the person they care for in the safest way possible for them and the person they care for. Next slide, please. PAMIS set up a family carer advisory group where 5 of us met regularly over 6 meetings to share our ideas and our wishes to be included in the National Postural Care Strategy, both the learning framework and the resources. 3 family carers are members of the National Postural Care Strategy Group, and we represent the Family Carer Advisory Group. There were consultation sessions to add to the content and the outcomes of the national strategy, and 11 families have made contributions featured actually in the strategy. Next slide, please. These contributions are family carers sharing their stories and their experiences. They have given quotes which are included, and one of my family carer colleagues actually designed the logo. And of course, there were lots of lovely photographs of our young people and their families within the document. But most importantly, our experiences are acknowledged by being included. Next slide, please. The document was finally launched in the middle of the pandemic on June the 3rd this year, with PAMIS family carers very much involved with the online publicity. Next slide, please. The pandemic could have floored PAMIS from further training, but family carers are made of sterner stuff. We continued our activities after setting up the Family Carer Strategy Group, and then we created our Family Carer Zoom forum to look at the delivery and the design of postural care training to be delivered by Zoom. I have also been involved in a family care in PAMIS moving and handling course, which offers sessions for family carers to look at ways they can use their equipment better or share some good ideas and safer moving and handling during the pandemic. Next slide, please. As a family carer, I am proud of the courses we have now created to be delivered by Zoom. We have held several 3-hour, 1-day over 4-week courses for family carers and professionals. We have also had several student nurses and allied health professional students complete the course. Delivering an online course took an enormous amount of work. We needed to create new materials, new films to replace group work, and ask participants to take on homework, and sometimes it might seem really daunting. We designed a week-by-week program for participants, including links to a range of really helpful materials. And we crossed our fingers that people would come. We evaluate after every session and at the end of the course as well, so that we can hone our skills in achieving the best practice. And although there are many advantages to face-to-face learning, we are actually finding that we reach out to families that otherwise could not attend our teaching, such as families living on the islands. Thank you for listening.
Well, many thanks to the PAMIS stream for this really touching and insightful presentation. I think you've all deserved a big round of applause. There's an applause button in reactions, so I suggest to activate it. Many thanks. And I think that really you highlighted also well the benefits of co-production. But in particular, Pat also explained to us so well and so frankly, and many thanks for the courage, Pat, to be so open to frank the challenges of initiating co-production. And I think what you've gone through is what I've described in my research, the outside-in pathway to co-production, you know, to bring on co-production coming from local communities and approaching public services. And, you know, that is sometimes very difficult, as you experience, because not everybody is open-minded and willing. And I think that is a lot more challenging than the inside-out pathway to co-production, where public services invite local people, you know, to help them to improve the public services. But I think what you have described shows us there's a huge potential outside, using more the outside-in pathway, you know, using more experts by experience, your knowledge, your hands-on experience, your social networks. So keep going. And your recent experience with digital co-production, which Jenny provided, also sounds very encouraging and maybe helps you to crack some issues with accessibility. So many thanks for your contributions. And I could bet that there are lots of questions, comments, concerns. So I would like to invite all our participants to a Q&A session. If you have any questions, please either use the chat line or simply raise your hand. If you look at the bottom of your Zoom screen, again in reaction, there's also raised hand. So just make yourself visible, you know, whatever you do. Clapping is always fine by me, or give us a shout. So, and any questions? Otherwise, there's also the opportunity to have a discussion after the break.
We've got Lindsay who's got her hand up, Elke. Lindsay.
Okay, Lindsay, you've got the floor.
Hi, thank you so much, guys, for sharing all of that. I'd commented in there, I used to work as a carer myself. I don't work quite in that sector anymore. How did you guys, I often found as a carer that we bumped into some of the same issues on a much smaller scale as you described, Pat. As people who knew people very well, we spent a lot of time with people, sometimes more than our own families, when we were working, and that kind of the point where you're just cut off, it's a no, and we're not going to tell you why. It happened to us as well. Did you find you had support from within the care team who knew Lauren, or who know Lauren and work with her, and that it was the more strategic level that you really struggled to get to listen?
Well, it depends on who it was that we were approaching. The Lauren's care team, whom we've always had really excellent relations with. Well, she has two care providers, one for a day service, one for her house. We've always had really good relations with them. However, and it was the Lauren's house staff who identified the problem. The issue for them is that social work effectively has a stranglehold over what they do, because it's social work who pays them. And it was made very clear to them by social work that they were not allowed to provide any support, regardless of their willingness to do so. They weren't allowed to, and essentially, I'm paraphrasing here, but there would be repercussions if they did. And so therefore, we were effectively on our own, other than our PAMIS colleagues who supported us. But we were deafened by the sound of doors shutting in our face. And actually, I saw early on, I saw advice from a solicitor who is an expert in this type of situation. And she told us, you're going to have to take on the system. And I didn't really understand at the time what she meant by that, but I understand now, because it's taken us 3 years and we have had to take on the system. And if we hadn't had lots of the links that we've had through PAMIS, then we wouldn't be in the position that we are now. So we have made some progress, but as I said in the presentation, it's taken 3 years and counting. And a lot of the progress that we've made has been because of representations that we've made on our own behalf, but also representations that PAMIS, and Jenny in particular, has made on our behalf, and other organisations like SCLD and the Mental Welfare Commission and so on. But essentially, it was us and Jenny, and it's been not to put too fine a point, it's been hellish, and still is. I'm still, when I go to bed at night, I'm still not sure if I get a phone call, I'm going to have to get up in the middle of the night and go, because Lauren will be on her own still, even after all this time. But I'll stop there. I keep going forever on this.
Thank you for that. I was just wondering, when you were talking about the staff position, I've been in that position myself, and I do wonder the other issues that we see in health and social care, such as incredibly high staff turnover. I would imagine that those frustrations are probably a part of that as well. It is very frustrating. A stranglehold is probably about correct between your job or what you feel is the right thing to do.
And Lauren's staff are wonderful, and they not to put too fine a point on this, some of them do love Lauren. They've been looking after her for 10 years, some of them, and for them to have to put her in the back of an ambulance on her own with a bit of paper that has hospital passport printed on the top of it would be devastating. They would be so incredibly upset by that. So we were doing it for Lauren, we were doing it for us, but we were also doing it for them and all the other people. And that's why we could never ever back down. There was no, once we started this, there was no way back, because I would never have had a night's sleep again. And so Lauren is in that position, but Lauren is not unique. The social work edict ensured that nobody with special needs, and special needs, that was their phrase, nobody with special needs who had a care package would be funded in that way. So we're talking about many tens of thousands of people, possibly hundreds of thousands of people.
Okay. Could I just add in, Elke? I mean, I just think the hope, isn't it, is that this social care review, which certainly has taken its time to listen to these stories, and it's been 3 years, but there seem to be some doors opening up now. It's learning how to really listen, isn't it? And I just think, I mean, one of the final things that we had wanted to say was, you know, there are obviously, as you say, pockets of really great practice, but how do we make that great practice real? And I think, you know, some of the discussions we've been having more recently, and the exciting bit about having us all together today is thinking, well, how do we turn things on their head and make them different? One other thing I did want to add in just very briefly as well was actually one of the big barriers that we had, and you highlighted in your slide, was also about families having to put so much of their own time into this and having the ability to do that. And one of the real successes we've had with the postural care is that we've actually been able to pay families to contribute, so they are paid in an equal way to the practitioners, which again, you know, as an organization, you sometimes can feel incredibly guilty asking families to give up so much time when, you know, I do actually get paid and they don't. So, but that was yeah, an interesting barrier that you put up as well, I thought.
Okay, so I've seen there's some more hands which were raised, but I suggest it's time for a break. Co-production, it also takes a bit of refreshments, fresh thoughts. So let's have a 10-minute break and reconvene at 10 to 3. You'll be invited straight into breakout rooms, and we'll pick up the question which Jenny just raised. How can we scale successful co-production initiatives? You know, how can we make effective co-production more mainstream, so it doesn't just remain a little pilot project, but also what are the challenges? And that is the third question, which is not in the slides. How can we overcome the challenges? That's the question for to win the big chocolate box. Okay, so 10 minutes break. Many thanks to all of you. And if you have any more questions, please feed them in the chat line. We are going to collect them and either get back to you during or after the breakout rooms, or we'll contact you in person in writing. Okay, so many thanks and enjoy your break, your tea or coffee or whatever you fancy.